Hello everyone and welcome to our 19th seminar of the Aphasia CRE Seminar series. I'm Caroline Baker, co-facilitator of the seminar series. La Trobe University acknowledges that this event and our participants are located on the lands of many traditional custodians in Australia. We pay our respects to elders past, present and emerging and extend this respect to our First Nations people joining us online today. We warmly welcome you to our 19th seminar, crossing Australian state borders to Western Australia and gathering many attendees for Dr Emily Brogan's presentation. What is aphasia therapy, treatment fidelity and aphasia? Before the formal introduction, let's briefly cover some housekeeping. Please be patient with us and the technology today. We have recently switched software platforms to the Zoom webinar package. Our apologies in advance if there are any disruptions to your viewing during the seminar. The seminar is being recorded on Zoom and will be available to access along with past webinar videos via the website. Just click on the resources tab. Videos are usually uploaded 2 weeks after each seminar, and we acknowledge that many are still facing difficult and uncertain times during COVID, particularly our international colleagues. And a reminder that the CRE has developed a repository of aphasia-friendly COVID-19 resources, and these have been sourced from across the world. You're welcome to use these resources in your practice. We have recently switched platforms for facilitating seminar questions. We now use the question and answer function on the Zoom toolbar at the bottom of your screen. Enter your question at any time throughout the presentation and please keep them brief. You will also be able to see questions asked by other audience members. Like or upvote a question to show those of most interest to the group. Dr Brogan will answer as many questions as time will allow at the end of the presentation. And please reserve this question and answer space for questions only and no other comments. And of course, please engage with us on social media via Twitter and Facebook. Feel free to tweet along today and use the hashtag Aphasia CRE. And join us at our community of practice if you haven't already done so. We welcome people with aphasia, their family, friends, health professionals, researchers and organisations to join the Aphasia CRE community of practice. Benefits to members of the community of practice include a regular newsletter, updates about events and activities, contributions to research, networking opportunities and more. The CRE is always looking for financial support. If you wish to donate, please see our website for details. Thank you. Now I am delighted to introduce Dr Emily Brogan. Emily holds a postdoctoral research fellowship with the Aphasia Centre for Research Excellence in Program 2, Treatment Effectiveness. Emily completed her PhD in 2019 in treatment fidelity in the Very Early Rehabilitation in Speech Randomised Control Trial, also known as the VERSE trial. She continues to practice as a speech pathologist in acute care and rehabilitation in Perth and is passionate about supervising speech pathology students and her committee role with Aphasia WA. Thanks so much, Emily, for presenting for us today.
Thank you, Caroline, and I'll just get set up and then we can get going.
That looks good.
Great. Okay, so thank you for the lovely introduction and welcome to my home here in Perth. It's quite a rainy day today, unlike Perth, and I would also like to acknowledge the traditional custodians of this land, and that's the Noongar Whadjuk land, where I am in Perth, and their elders past, present and emerging. So I have the pleasure of being a postdoctoral research fellow with the Centre for Research Excellence in Aphasia, and I'm based at Edith Cowan University in Western Australia. And one of the perks of this role is that I get to be here presenting to you all today. And I also had the option to be able to choose my topic. So I've chosen to talk about my PhD research and then what's happened subsequent to that in the last year or so, and that's in treatment fidelity and aphasia. And the central question for me that's really developed since being an undergrad and then a new grad speech pathologist is about what is aphasia therapy. And it's something that has really begun to solidify recently for me, and doing a PhD in treatment fidelity was central to that, because I think treatment fidelity can help to answer some of the questions we have about what is therapy. And I describe myself as a research romantic, and this is why. In research, there is the freedom to choose the problem that you want to solve. And I chose to research aphasia therapy partly because I didn't feel confident in it. I practiced mostly in swallowing and dysphagia assessment and treatment in an acute care hospital in Perth as a new grad clinician. I didn't do a lot of aphasia therapy, and so it was an area of professional development for me. And because I didn't feel like I had a full understanding of it, I felt like I couldn't help people with aphasia like I wanted to be able to. So that's sort of how I got into doing research in aphasia. And treatment fidelity provides the structure to answer some of that question. And it links to that it's very important to ask the right question. So that reminds me of this quote by Albert Einstein: "If I had an hour to solve a problem and my life depended on it, I would use the first 55 minutes determining the proper questions to ask." And I think it's important that research is designed to answer the question. It doesn't always matter what the answer is, but that the research has the rigor to answer the question. And back when I was a new grad clinician, if you had have asked me what is aphasia therapy, probably my answer would have been somewhat like this: it's complicated. And much like I'm talking about treatment fidelity today, much like fidelity or infidelity in relationships, which is not what I'm talking about, I'm going with the research angle, aphasia therapy is complicated. So what does the theory say about aphasia therapy? Well, we know that neuroplasticity is important and that there's a window of time where the brain can change itself after a brain injury. And I've got an article referenced here, Hordacre, published this year in Neural Rehab and Repair. And that was a worthwhile read, and demonstrated in humans for the first time that window where the brain can change itself at a neurophysiological level. So I recommend that if you haven't already come across it. Also important in aphasia therapy is Hebbian theory, that is neurons that fire together, wire together. And that with repetition that we do in therapy, there'll be neuronal change, that will be learning, and there'll ultimately be behaviour change. So that is some of the theory, as we know as clinicians and researchers, that is the basis for aphasia therapy. What does it look like in the literature? Well, the literature tells us about what it looks like in practice, that it's often individual one-to-one therapy. 61% of therapists report a combination of approaches. Therapists frequently use clinical guidelines to guide what they do in practice, and that there are frequently poor treatment descriptions in journal articles. So also clinicians on this call will know that if you go to a journal article and read up for how to do the treatment, then you might not always get a good idea of actually what to implement behind the therapy door. So in sessions, aphasia therapy looks like tasks. And I know a lot of the students that I have in my clinic, they start out getting very focused on the task and expecting that that task will be the foundation for change in therapy. But I think as you get a bit more experience, you realize that a lot of it is to do with the person with aphasia. And this is called the client acts. So what the behaviors that they're doing in the therapy session, that will be their learning. And as a therapist, we have inputs that then modify, shape, using cueing, feedback to shape those client acts. Within the task in an aphasia therapy session, there are teaching episodes. And within those teaching episodes, there are ingredients. And we hope that some of those ingredients are the active ingredients that help to result in behaviour change for the person with aphasia. And then, as we know, there are a whole lot of things that are very difficult to measure in a therapy session. Some things that come to mind are the motivation of the person with aphasia, the rapport between the therapist and the client, fatigue, personality. They're all very difficult to measure, but have an impact on the therapy that is given. So I felt like the logical next step was to ask Twitter what they thought of aphasia therapy. And many of you responded, thank you. So you can see some of the responses on the screen. What is aphasia therapy according to Twitter? And there were lots of positive responses about it being meaningful, person-centered, boundless, enablement, interaction, access. Lots of positive responses about the person with aphasia being central to aphasia therapy. And you can see in the middle there, one of the maybe less positive responses from Professor Linda Worrell, because I had been a bit provocative and I had said that in my question to Twitter, that my answer was that it was naming and I was designing it to be provocative. And Linda Worrell said, if it is, I give up. So another thing that came through on Twitter and really helped me shape this talk was that there was a gap. So there was a difference between what therapy is and what therapy should be. What it is, impairment focused, cookie cutter, but what it should be, functional, dynamic, personal, co-constructed, and also a comment that it's misunderstood. And so that's really why I research, acknowledging that there is a gap between what therapy is and what it should be, and trying to solve that problem. And ultimately, what we're aiming for is therapy to generalize outside that therapy door. And in the area of treatment fidelity, that's called treatment enactment. And at the moment, we know that a lot of our therapies are not generalizing. And in research, it's also very complex to measure what happens outside the therapy door. So there is a gap in what we should be doing and what we are doing. Every complex problem has a simple solution that doesn't work. What we're dealing with is very complex, and treatment fidelity is a way to acknowledge that complexity with a complex evaluation of treatments. So why is therapy so complex? And I have gotten this figure from the Release Collaboration paper last year, Communicating Simply but Not Too Simply. And I acknowledge that that is their intellectual property. And you can see, I think this figure demonstrates very nicely all the different parts that are involved in therapy. You've got the person sitting in front of you, the person with aphasia, but then you also have the therapist. Then you have the therapy and the regimen, everything that's been designed to that one task. So there are so many components that are interacting at any one time to make therapy so complex. I've mentioned this word a lot, treatment fidelity. I'm going to break it down a bit. The first sentence there, the degree to which the administration of a treatment corresponds to the specified protocol for the implementation of that treatment. is pretty complex and unwieldy. So that is that the treatment that the researcher intends, does that actually happen in reality behind the therapy door? That's also involved with looking at, are the two treatments that are given in the research, or however many treatments are given, treatment A from treatment B, are they sufficiently different enough? Because if they're not different, then the research question won't be able to be answered of whether one is superior to the other. Treatment integrity is how close that protocol is adhered to. Now, I have spent the last 4 or 5 years of my life on this topic. So according to me, if I was to come up with a definition, and because I've seen how broad treatment fidelity can be, and that it is really to do with what therapy is about, my definition is making sure the study is designed and implemented to answer the question. And that's, I guess, our ethical obligation as researchers and the rigor that we put into what we do. This comes from the Behaviour Change Consortium, and it is the 5 different parts of treatment fidelity. And this is quite widely accepted. So this is the model that I draw on. The first is study design. Is the study designed to answer the question? So if you're comparing treatment A and treatment B, has it been set up in such a way so that those treatments are different and you'll actually be able to have an outcome with efficacy? It might also be, have you got sufficient, have you identified the different doses that will be happening in the research? So it's about at that beginning design phase of whether the research is set up to answer the questions. The next part is provider training. And this is training the therapists in the research, and many of you will have been therapists in research trials, and possibly in the VERSE trial that I'm about to talk about. Has there been training, manuals, mock therapy sessions, resources that's provided sufficient training to the therapist to be able to implement the treatment? The next is looking more at what actually happens rather than the preparation, and that's the delivery of the therapy. Was the therapy delivered by the therapist in the way that it was intended to be? Receipt is looking at the person with aphasia in aphasia research, and did that person with aphasia receive the treatment the way it was intended? Because the therapist might be saying all of the things according to the manual, but the person with aphasia might not then be able to demonstrate the actual learning and behaviour that the therapy is designed to produce from them. And the last one is enactment. And that is seeing what happens beyond the therapy door. Can the person with aphasia demonstrate those behaviour change skills outside of the therapy room? And I guess the ultimate aim of our treatments is for that, and research needs to take that into account and measure what's happening beyond the therapy room. And this is, all of these parts are one of the reasons that aphasia research is so complex. So I've mapped some of those treatment fidelity parts onto the model from the release paper about therapy. And there are many aspects where there's so many overlapping parts for treatment fidelity to address, both in terms of what's planned by the researchers, but also what actually happens. And I guess this is one of the reasons that our therapies are labelled as a black box intervention. So much going on and we're not exactly sure what's in that box. So the researchers need to design the trial to answer the question. They need to check that it's implemented in the right way, but they also then need to report it, because not many people will know what's going on if it's not reported. And the tidier statement addresses treatment fidelity and emphasises it as being highly important, with items numbers 11 and 12. So this is when reporting an intervention. The studies need to report how fidelity was planned for in the trial, how the study was designed, how the therapists were trained, but also what happened in actuality. So was the therapy actually delivered as it was said in the manual? And frequently studies will report what was planned, but then either not measure or report what actually happened. Did it go as intended? So why does all this matter? Well, it matters to therapists because we draw on that research to then be able to implement a therapy. And we want to have confidence in the research base and know that best evidence. It matters to researchers because we have an ethical obligation to design studies that will answer the question. It's using taxpayers' money. So we want to be able to put enough rigor into that research to answer the question. And it also is central when researchers interpret other evidence to know the rigor that was used. For people with aphasia, it will have a direct flow-on effect to the treatment that they receive. If that treatment has been adequately investigated, and then there'll be more confidence in the efficacy of the treatment, which will have a flow-on effect to the treatment that is then given. In the community, taxpayers fund research, so there is a need for them to have confidence in the research that's done and the rigor. And then policies, guidelines are based off of research. So if research can do a better job at answering the question, the guidelines will then be more thorough, and that will have a flow-on effect to the therapists and the people with aphasia. So back to Twitter, what therapy should be and what therapy is, and that gap. So treatment fidelity helps to bridge that gap. It's concerned with what the researchers plan and then what actually happens in the trial. And so aphasia research, reporting of treatment fidelity has increased since it was initially investigated in 2013. And it was reported that treatment fidelity was in those studies at 14%. I then investigated it in 2019 and found 21%. That was within randomised control trials reported on treatment fidelity. And then Dipper and colleagues this year reported it at less than 30%, but about 30%. So there's been an increase, but for how important it is, I think we can do better in this area. And certainly with trials to be published coming up, I can think of Compare, that has very rigorous treatment fidelity aspects. There'll be some VERSE publications as well this year in this area. I think that number will continue to increase. So I'm going to apply now what I've been talking about to the VERSE trial. And that's the Very Early Rehabilitation in Speech randomised control trial published last year. So this had a really high level of treatment fidelity procedures. And we're going to look at what therapy was and what therapy should be. So applying some of these concepts to the trial. I'll just refresh a little bit for those who aren't familiar with the VERSE key findings. And you can see the reference at the bottom of the screen there if you would like to investigate further. So the overall finding was that early aphasia therapy is beneficial, but more is not better. And that finding came from investigating 3 arms of therapy. This was in Australia and New Zealand. There was the usual care therapy arm, so that was therapy as normal. Then there were 2 intensive treatment arms, and this was 45 minutes of therapy 4 to 5 times a week. So there was the VERSE arm that gave that intensive therapy, and it was a prescribed therapy with certain therapy principles that I'll go into. And then there was an intensive therapy arm also given 4 to 5 days a week, but the therapy in that arm, Usual Care Plus, wasn't prescribed. So therapists could make their own decisions about what to do, but they needed to give it intensely. And again, the conclusion was that more was not better, and that low intensity therapy of 2.5 hours per week in the early phase was the most beneficial, starting at less than 10 days post-stroke, 2 to 3 times a week, 30 to 40-minute sessions. And I would direct you to Erin Gadecki's publication and colleagues from last year, if you would like to read more on that. And there's also a couple of other publications that relate to therapy fidelity and the VERSE trial, and there'll be some more pending this year as well. So please, if you're interested, do read up. I'm going to be presenting some of the results included in the 2 right-hand side papers there, as well as some in-press results. So within my PhD, I watched a lot of therapy, and I watched the therapy videos that were collected within the trial. And that was one of the gold standard measures of treatment fidelity that was included, where therapists in the intensive arms of the trial recorded themselves in the therapy sessions with the person with aphasia. And there was a therapy fidelity monitor that would then watch those videos and make sure that the therapist was adhering to the way the researchers had designed the treatment. So it's a way to see what happens in actuality rather than just what was planned. I transcribed 53 of these videos, and that resulted in many words typed, 149 therapy tasks watched, which was 46 hours of therapy, and I watched people with aphasia make over 12,000 mistakes. And I'm going to go through the results that I was able to get from those videos and contrast it against what was planned or what should be and what happened in actuality or what is. According to those areas of therapy fidelity, we'll start with study design. So it was planned to be intensive treatment, 20 sessions of 45 to 60 minutes. And it was planned that within those 2 intensive arms, that there would be 660 videos received from therapists based on those sessions. And in actuality, 75% of the participants received greater than 15 hours of intervention. There were 10,805 sessions conducted, and that was across the 3 arms. There were 431 reports of a deviation from the therapy plan, and that was reported by the therapist. But considering how many sessions there were, it sort of sounds like a big number, but when you consider out of the total number of sessions, that represents 3.9%. And there were 437 videos actually received. And I think that makes sense because you're not going to hit that number that you want to, the 660 that were planned when you consider technological issues and other things. So still a very healthy number of videos received. The next part of treatment fidelity, training providers. So standardized training was given, therapy manuals for the particular prescribed therapy. There were practice sessions, there were video recordings given, and then there were ongoing newsletters and updates to keep therapists on track and minimize the drift from the intended treatment. In actuality, 430 therapists across 17 acute care sites and 45 subacute hospital sites were trained, and 100% received all of those, the 2 to 3 hours of training, and there were 43 newsletters sent. So those 2 parts, the study design and the training of providers, are about the way in which therapy is planned to be done. And if we move on to the next part, which is the delivery of the treatment, the researchers will say how they think the treatment should be delivered, and then we'll look at what actually happened. So this is within the VERSE prescribed intervention. So this was testing, it was a sub-hypothesis, so not to do with the intensity of the treatment, but whether a treatment with these principles was superior to a usual care treatment. And the principles were that there was experience-dependent learning, there was an emphasis on errorless learning, so making less errors was preferenced, a verbal focus, a conversation focus, and that cueing and feedback were core therapy techniques. So these were then evaluated by the therapy integrity monitor from all of those videos. So those videos were watched and then they were given an adherent or non-adherent result for those different principles. And you can see there on the screen that in excess of 84% of therapy sessions were adherent, and most quite far above that, sort of in the 90% for being adherent to those key therapy principles. So can say from that with confidence that the intervention was delivered with a high integrity in actuality for what the researchers planned. And my PhD was a sub-analysis of this, looking at 53 videos, transcribing them and looking at utterance by utterance, whether they were adherent to those principles and also what happened in the therapies. And the usual care and the verse treatment arms, on the variables that I looked at, they were things like the number of errors made, the number of cues used, the number of times those cues were successful, the amount that the person with aphasia said. Looking at it utterance by utterance, those two treatments didn't differ at that level. And so whilst at a broader sweep and a bigger picture look, they did appear to be different, at the utterance level, they were not manifesting as different. And this is really key for researchers to know that potentially those two treatments may not have been different enough to produce a difference in efficacy. And that is a hypothesis, because I will emphasize that it was only a small sample of the overall therapy given. A bit more on what therapy looked like. And I guess this partly prompted my tweet about therapy being naming. So across those 53 videos, there were 69 different tasks given, and there was an average of 2.9 tasks per session. And the majority of tasks, 47%, were at single word level. And then you can see in the verse prescribed, that's the conversation, verbal-based, error-less treatment, that there was only 18 different tasks across 28 videos. And I think that fits with a protocolized manual-based intervention, that you would have some less tasks, even though there was still room for therapists to choose tasks. Whereas in the usual care arm, usual care plus, there were 51 different tasks across 25 videos. And on average, 3.8 tasks per session. And in the usual care, where therapists had that free rein to choose the therapy that they wanted to do, 57% of the tasks were single word level. And I will just emphasize that the groups were balanced for severity. So it wasn't that everyone was severe and at single word level. They were balanced across mild, moderate, and severe, and still quite a preference for single word level tasks. And you can see in the Wordle on the left that the biggest task name that came through there was picture naming. And the top 5 tasks were picture naming at the single word level, generating different semantic words, picture description at the sentence level, automatic speech, and then conversation. And I will say that this was from the usual care arm, so not the prescribed therapy, but the where the therapist could make more decisions about the treatment type, had free reign of treatment type. Therapists did the majority of talking in the trial and in this subsample that I looked at. So that's both in terms of the number of words and also the number of utterances, or more phrase or sentence level. And I think this is interesting to reflect on. I know that it probably doesn't surprise anyone that therapists do the majority of talking in a session, given that we're working with people who have communication difficulties. But I think it is just pause for thought in terms of some of the neuroplasticity principles and use it or lose it, trying to get someone to talk as much as they can in a session. Also on neuroplasticity and adult learning principles, that 28% of those therapy sessions included a discussion about the rationale for why that therapy or task was chosen. And I was a little bit, I thought that that number may have been higher, given that often we're working with adults, and that motivation and adult learners need to know why they're doing something to help them learn. So that 28% of the time, something about, I was quite liberal with marking this too, something about why the therapy was being done was mentioned. Task explanations in terms of what to do in the task were very frequently given, and there was about 2.3 of those per session. In terms of how the treatment was received by the client, so it was planned that it would be an errorless treatment with a verbal focus and a conversation focus. And how that actually manifested, when watching some of those videos, there was an average of 228 errors per session. The person with aphasia was able to self-correct themselves about 15% of the time. They said about 1,689 words per session on average, across an average utterances of 479, and 28% of what they said in the session had errors. And I think this provides an insight into some of those stats of what's actually going on in these sessions. And in quite a large sample of 53, the average numbers of how many errors do people make in a session? So I can direct you to that paper for some more data in that area. And people with moderate aphasia made the most errors. And this was across whether they were speaking at sentence level or word level. So the word level errors and sentence level errors were greater for people with moderate aphasia. And people with moderate aphasia also had the highest number of utterances per minute. So I think they were saying more, and there was a bit of an efficiency and accuracy trade-off of people with moderate aphasia saying more, but also making more mistakes. And I think at a surface level, we can think, well, if you've got more severe difficulties, you're going to make more mistakes. But actually, it was that moderate group where there were the highest number of errors. Cues were successful, cues given by the therapist, on average 40% of the time. And this is to do with how the person with aphasia is receiving the treatment. So cues used, and I have included a direct model, so saying the target word and getting the person with aphasia to repeat the target word back. I have included that as a cue, even though it is sort of at the least difficulty end of the hierarchy. So these are the average number of cues used in a session. Phonological cues were the next most common, semantic, sentence completion, and so on. And then when you look at how successful they were, so did it actually produce the target response from the person with aphasia? As you would expect, a direct model was the most successful. Even so, successful 48% of the time when you give them the answer to get them to be able to verbalize it. And it then goes down orthographic, sentence completion, phonological at about 40%. And you can see a real reversal in the orders there. Semantic percent in this semantic cues, in this sample was down at about 14% for success at getting the person with a say target word. So even though semantic cues were given in the third highest type of cue given in frequency, the success was down at 14% and at the bottom. Enactment of treatment I spoke about before, which is the generalisation of the treatment outside the therapy room, wasn't a focus of the VERSE trial to look at that. One way in which it was conceptualised within my PhD was looking at what part of those treatment sessions that I had transcribed and analysed was associated with a better recovery at 6 months after stroke. And this was just within my sample. And the recovery was measured by the Western Aphasia Battery at 6 months. And I looked at what was happening in those therapy sessions within 1 month after stroke. And what was associated with a better recovery was verbal utterances, so the amount the person was able to say. Percent total words with errors was sort of negatively related. So if you were able to say more with less errors, then that was predictive of a better outcome. And also the number of times a cue was used with success. So the number of times a therapist used a cue and the person with aphasia was able to say it. These were the three things that came out of that analysis that I did to be related with outcome at 6 months post-stroke. And this is not strictly looking at treatment enactment, but I just have popped this in of a way in which we did have a go at addressing that, because it was the outcome at the end outside the therapy door with what happened in the therapy session. And I do caveat this in that it was just within this small sample of the therapy that was done. And some of these things may also be logically related with a better outcome on the WAB. So if you are able to say more, then you will likely do better on the Western Aphasia Battery, being a predominantly verbal test. Still something to think about and investigate further. So I'm just going to recap the gap of what it should be and what it is. So a bit of a summary of what I've just talked about. Therapy needs to be based off different treatments being researched. But in actuality, some of these treatments, as demonstrated in this sub-analysis with inverse, the treatments were similar when they were evaluated. So although a treatment may be designed to be different, in actuality, it may not come across that way. Going back to Twitter as well, the results of what it should be: holistic, functional, salient, and often what it was in these therapy videos, picture naming with generic items. So it wasn't, most of the time it wasn't pictures that were personally relevant to the person, it was your standard sort of picture naming set. What it should be: use it or lose it, experience dependent. What it was: therapists doing most of the talking, and we don't know that level of talking from the person with aphasia is not efficacious, but I think just pause for thought in that the therapists do talk the majority of the session. And what it should be: motivated adult learners, but in this sample, frequently minimal explanation of the therapy rationale or why that therapy task was chosen. I think the challenges moving forward for research is making sure that beyond the therapy door is measured. And that's treatment enactment that I've spoken about. Does it generalise beyond the clinic room? Also, seeing and trying to ensure that treatments that are planned to be different in actuality are different in the research, so that that rigour is there to answer the question, treatment A being different from treatment B. And I think with talking-based treatments and traditional speech-language therapy treatments, in actuality, they may not be coming across as different. And then measuring all that complexity of therapy. Where do you start? How do you do it? The way you plan in which to do it, does it actually happen? Then how do you report it? It's complex. So measuring all those parts of that release model that I showed, but also making sure that, you answer the question that you designed to, and that may include things like motivation, rapport building, emotion, personality, that are really complex to measure. And I don't have the answers, but just that we can think about ways in which they can be measured and put that on the radar. So I'm going to slightly tweak my question and answer for Twitter and re-answer it having done all of this research. So no longer my new grad answer of it's very complicated. I still agree with that, and I was being controversial in saying on Twitter that it was naming. But I think the gap for me is that what therapy is a lot about what's behind the therapy door. I think that the biggest challenge and the biggest opportunity to help people with aphasia is actually about what happens beyond the therapy door. And I think going forward, that is going to be more of my focus. So thank you very much for listening, and I welcome questions.
Thanks so much, Emily. We really appreciate your talk, and it was fabulous. You've done such a great amount of work in this area, and yeah, it was really lovely to hear in such a clear and interesting presentation. So we've got lots of questions and we'll start going through some of those. Thank you everyone for your questions. Professor Linda Worrell asked, can you explain more about why the VERS therapy and usual care were similar? Was it contamination, or is usual care just similar?
Yes, and this is a bit of the $1 million question. Again, I will just emphasize the caveat that I looked at a small sample, and yeah, I have been thinking about this, and I've reflected on this in some of the publications as well. It can be a positive, I think. So VERS was designed with a lot of those principles of what we thought therapy should be. And we also know that it was implemented with high integrity. So therapists did what was intended. So therefore, if usual care looks similar, that you could conclude the usual care therapists out there are also using all of those principles and delivering the therapy as best they can with best practice principles. So that's one explanation. The other explanation that I've been thinking about is how much control we do have over the person with aphasia and the output that they give in therapy, and whether there is, being a communication impairment and a talking-based therapy, a lane in which that they can go in, and that they may not be able to demonstrate the receipt of the treatment in the way that we intend. And so regardless of some of the things that the therapist does, the cueing, the feedback, perhaps the person with aphasia will only be able to respond in a set way, and therefore the treatment can only be delivered in that way, and those two treatments might not be different. So they're just some thoughts. Thank you, Linda.
Thanks, Emily. Jacqueline asks, in your analysis of the therapy sessions, session to session, did the tasks remain the same? i.e., did the structure of the therapy provided remain constant over sessions?
Okay, thank you, Jacqueline. So I will clarify here, I didn't go a lot into the methodology. I was taking more of a broader view. I looked at 53 random sessions, and so I didn't look session to session across the same person. So that would have provided, that is analysis, added to the list of one thing that I would love to do next, is looking more at, so there were 4 videos received for each person and seeing how the therapy changed across those 4 videos. I will say that no 2 therapy sessions looked the same, and that there was that really high variability in tasks. So I think that tasks were frequently changed within the session and across sessions, but those therapy principles and the way in which the therapy manifested was similar.
Lovely. Thanks, Emily. Fanny asks, how did you choose the 53 videos?
Yes, so that was a random sample. There was, I mentioned the 434, I think, therapy videos. And then the therapy integrity monitor, who was not me, did a randomization and let me know which ones I needed to review. And that was an ongoing process because videos were continually coming in. So it wasn't done at the end. It was as videos were coming in, they got added into the pool and then randomized, and I would pick, and then I would analyze that one.
Lovely. Jacqueline says, I know a comment is not allowed, but when I heard the title of your presentation, which is excellent, the first name that came to mind is Sally Bing and her paper, What is Aphasia Therapy? That is for me a classic paper. To make this a question, has your research departed from her classic publication?
Thank you. Yes, so I am aware of that paper, and that really was central for me in forming my PhD research proposal and then going on throughout the PhD. And I would have to go back and refresh exactly on it, but I do remember the emphasis in that paper. There was talk about the structure of therapy and also the cueing and feedback and the types of feedback in particular, that they were really central to therapy. And that is what I then based that analysis off in my research. And I think, yeah, I'd have to go back and refresh, but I would say that those classic parts of therapy are still there.
Good, thanks, Em. Relative to the therapist doing most of the talking, do you have a sense of how much of this was clarification, elaboration, summarisation of what the client had said, i.e. more talking but communication partner strategies?
Yes, so every utterance that I did transcribe and code, I did subcode for what the content of it was. And I am going to publish that data. I believe some of it is in those two papers that I mentioned in the presentation, behind the therapy door, and then the one around the dose and active ingredients. So I would refer to those to look at for more of that, because I coded the feedback that the therapist gave as well as the cue type, and whether they gave problem-solving type feedback, whether they were clarifying, and so there's supported communication strategies. And that is also something that I want to delve more into with the data that I have, is looking at that in more detail. So stay tuned, Sarah.
Great. Fanny says, I was wondering if you find it effective and why to provide group speech therapy for people with aphasia. Also, are there studies examining aphasia group therapy? And thank you very much for your answer in advance.
Thank you. So that wasn't really a focus of my research, group therapy, but certainly there is a wealth of research into group therapy, and I would advise you to stay tuned for more for the Centre, from the Centre for Research Excellence in Aphasia, with trials such as COMPARE being reported on, and they will contain a lot more data and a lot more efficacy information about group therapy. So in terms of it being effective, I believe so, but not really a focus of my research at this time. And the therapy in VERSE was individual therapy.
Okay. Chelsea asks, you said that usual care did more single word therapy than VERSE, group level comparison. Was there a difference in percentage of therapy activities at the word level when analysed at different severity within usual care? i.e. did less severe patients tend to get given more sentence conversation-based therapy than their moderate to severe counterparts, or was it still a mix?
Yeah, so there was still a predominance of single word therapy regardless of the severity level of the person with aphasia. And so there was more conversation-based therapy in VERSE because that was the way in which it was designed. But I think this question is asking about usual care. And again, it's an area I could delve in further with the data, and this is giving me lots of ideas of things to do. But in the sample I looked at, I think it was 57% of the tasks were single word level, and that was across the aphasia severity. So it wasn't just people who were severe who were at that single word level.
Thank you. When reporting the fidelity of treatment delivery for VERSE, what percentage of videos did they review? Yes, so 100% of videos were reviewed by the therapy fidelity monitor for a broader sweep at was the session adherent or non-adherent to some of those principles. And then I analysed a subgroup, 53 videos, which I think was 12% of the sample. And that was at that utterance by utterance transcription level analysis. Okay, great. Did you analyse how much time the therapist allowed the client to respond before jumping in? No, not in terms of time. I did have a look at the amount of errors that a person with aphasia made, but they would often have the therapist giving cues in between those.
So I haven't looked at time. That would be another study within a study to do. And the VERSE prescribed treatment was designed to be an errorless treatment. And the instructions were that the person with aphasia should have 3 to 4 attempts before moving on. And in actuality, it was in excess of that. So I can't remember the exact number, but I feel like the average was maybe 4 or 5 attempts before the therapist moved on. And that was when aiming for an errorless treatment. So that number may have been higher in usual care.
Okay. Any suggestions regarding how we can modify and tailor evidence-based treatments to improve cultural safety and relevance of therapy to communities outside of those traditionally included in the research base? Acknowledging that we are now getting some research about the needs of those communities, but not always the resources to go with it.
Thank you, Robin. I think this is a really important area, and unfortunately hasn't been my area of focus and not something that I can comment too much on, other than I identify this as a gap, and that probably what aphasia therapy should be is that the research has been based on a whole lot of different cultural groups, and that what it is at the moment is based on a select group, and therefore we are frequently generalizing things to populations that haven't been assessed. So I think this is a really important area, and I hope that the Aphasia CRE can contribute to that area.
Okay, as educators, we often drill into students how impairment-specific and measurable goals are for reporting purposes. I wonder how this may have a flow-on effect into biasing towards activities like naming that easily derive a percentage to show what was achieved in a session.
Thank you, Christopher. That is a great comment / question. Yes, I completely agree. And at the moment in clinic with my students, in fact this morning, talking about writing SMART goals, as you say, specific and measurable goals. And those tasks that are more easily constrained and measurable are probably single word tasks, picture naming tasks, because you can make a tally, you can say percent, correct, incorrect. And I think that is attractive from that measurable level. And that is where, as researchers, I think we can have a role in developing tools that measure different types of therapy that maybe are more conversation-based, or we can identify the really important active ingredients in therapy, the parts of therapy that are most important to measure, so that it might be a conversation-based task, but you're measuring one particular part of that. So I think definitely there is that bias towards really recipe-based goals that are more easily measurable, but this is maybe another gap of should be and is at the moment. I agree.
Okay. Thanks, Sam. We've got just a couple of minutes. Jacqueline asked, did you analyse how much time the therapist allowed the client to... Oh, we've done that one. She asked naming, but naming what in the therapy?
Yeah, so frequently pictures. That was what came through the most, and they were sort of more your generic traditional speech language pictures, rather than say personally selected targets or photographs.
Okay, and we'll finish with Linda's question. So from the first 10 days, people with aphasia are only getting impairment therapy, no information about aphasia, no counselling, no family, support, no mood screening. If so, no wonder people with aphasia are often distressed still in the first year post-stroke. Thank you for looking at therapy beyond the therapy door. Would you like to comment, Emily?
I will say that the VERSE trial and the focus of this was looking at the impairment-based therapy, and what I've reported is about that, but that doesn't mean that those other things didn't happen. And in fact, they did happen in excess of the impairment-based therapy that was given. But I agree with you. If that's not happening, then that is a very distressing time. And yeah, I think we can all do our bit to try and make sure that information counselling is given to people with aphasia and their families, because that's probably one of those really difficult things to measure that may be having an impact both behind the therapy door and beyond. So thank you, Linda.
Thank you everyone for your questions for Emily, and Emily, thank you for responding to those. We'll just finish off with the final slide. Thank you so much, Emily, for your presentation today. We really appreciate you sharing your findings. And a survey poll might just appear on your screen as I read through this slide. But if it doesn't, please feel free to contact us at the Aphasia CRE if you've got ideas for future topics or you'd like to join the community of practice. Our next seminar is Wednesday the 28th of April, and we are so excited to have Dr Sonia Brownset from the University of Queensland presenting with Dr Lisa Gillander from the Mater and Princess Alexandra hospitals. And they're going to talk to us about language and epilepsy and reasons for speech language pathologists' involvement. So we look forward to seeing you then in a month, and thank you everyone for joining us today.